such a minimum cost of care, these two, very minimum. But this particular hospice fourth level of care yields care that the others can't provide in that structured environment. It just can't be done. I mean, we're designed to yield a certain amount of care. The medicines and all that. Going home there and try to get your nurse to get some morphine or Ativan, Roxanne, or whatever, it's not going to happen. Because they're not, that's not the, if you want an order, I mean, we have to have doctor's order for equipment and all this, but I mean, it gets really technical when it comes to home health and other vineyards. So it is really, really unique, and it is such a necessary place of work for the levels of care. Just want to point that out.
My final point, because you said die with dignity. That means a lot. I know I was there with my sister when she drew her last breath. I had my hand on her chest when I just saw the life leave. And you know, before that, she was complaining. She couldn't swallow. She couldn't do any of that. And my sister was upset because it seemed like she was just struggling. We wouldn't know what to do. So the nurse came in. She said, "Okay, well, I know exactly what to do." It was some sort of pads or swabs or something that they gave her, and she just settled down. Other than that, it looked like she was choking and just, you know, just fighting to try to stay here. But it was, you know, when she calmed down, everybody calmed down, and that's what I call dignity. You know, that she had passed away with some level of comfort. I play that back in my head because I'm not, as I said, I'm not good at dealing with people in death. But I was able to sit there because I realized as her life passed that she wasn't hurting me. You know, I remember that with my mom, but she didn't have cancer or any of those things. But, you know, at a point, because she was such a giving person, I was glad that she passed on because I never wanted her to suffer. And when I saw my sister in that same situation, it was that care that gave me the strength to be there, to be by her side, and to see her life leave her. And I wasn't upset at all, not at all. So it's not so much for the patient as it is for the family.
Exactly.
That's what we miss. It's for those who are living. And the scars that it leaves for you to see that person passing on struggling. That's terrible. But anyway, that's
one of the last things that Brian told me before he became unable to even speak. One of the last things he said to me in his lucid moments was, "Thank you. Thank you. I'm at peace. I'm not hurting. Thank you."
Well, from a physician's standpoint, you know, I've had an opportunity and privilege to serve, in practice medicine for 48 years now. I've done hospice for the last 3 years, and so I've had to grow more and, deal with more things in the last 3 years than the other 25 years combined. Because when you have to deal with patients and families at this time of life, it's not a prescription they're looking for. It's not a treatment they're looking for to get well. It's something more than that, and you have to go deep within yourself. You have to go back to everything you've learned in life and everything you have to deal with. So it's a different kind of perspective. Many of my colleagues still aren't aware of what hospice is also. So we're going to, I think, need to take some efforts to educate some of our colleagues. We had a patient that we attempted to admit to hospice through Medicaid maybe 4 months ago. A man and his wife. The man was Medicaid with heart disease and COPD and a lot of other problems. His wife was Medicare. They came to my clinic one day, they were Rains, and they were sharing an oxygen tank. And because it took more than 2 hours to see them, they ran out of oxygen. So while they were in the clinic, both of them were struggling. The little woman weighed about 100 pounds, and so the tank was as big as she was, and she had struggled to get it back and forth. So I recommended we admit them to hospice because they were both with serious problems with heart and the lungs. They denied the hospice care. We talked to a doctor from the Department of Health and Hospitals, somebody get another general appointed, despite the fact that I think I gave, and we did a thorough.
We tried.
We did a thorough evaluation and assessment of this man, he was still turned down. And this doctor was just so cold with his assessment of what we were presenting to him in terms of what this man was at, or probably was at. I did hear that he died 2 weeks ago. And this doctor was telling me there's no way you can prove on your paperwork that he's got 6 months to live.
He actually lasted 7 months from the day of that hearing.
Yeah.
I sat down and figured it out. Big deal, we missed it a month.
Yeah, but he was, so that was a big argument that I couldn't pinpoint his time of death, which none of us can, of course, but that was what they were arguing in terms of theirs. So anyway, we appreciate the fact that we do have an opportunity to try to fight for our patients.
I think we need to get together some facts and figures, because as well as Roy and I know, it's gonna come down to dollars and cents.
Yes.
Well, the Florida study, Florida commissioned a third-party study before they attempted to eliminate their hospice Medicaid benefit, and the outcome was that it was going to drive people, like Dr. Cox was saying, it's going to drive people up that healthcare ladder. We can't go in the home and take care of them in that crisis in the middle of the night. It's going to be 911, emergency room, admit. It's going to. Ohio also conducted a third-party study before they attempted to eliminate it. That study found that instead of saving them money, it was going to increase their Medicaid expenditures $7 million. I emailed you a copy of them. The Duke study, conducted at Duke University, while it focused mainly on Medicare, it can be extrapolated to hospice, to the Medicaid population. It found that hospice saves an average of $2,000 per patient per day the last year of life. The published studies are here.
Unfortunately, they use an outside source to come up with the numbers. So
But they use an
are
objective third party.
And that's what you have to remember, a third party that has what we call neutrality, where they have no interests, it's equal playing field.
Representative Burrell, if you would like to copy those, I can run print you a copy too.
That would be good, because believe it or not, you have a lot more support than you know on appropriation. One of the probably the longest conversations or arguments that we had in appropriations when this issue came up was that issue, hospice, of all the other cuts that we were talking about, because there were a lot of legislators in there who have experienced this, and I think it hit home. And to get a conversation out of many of those guys who are aligned with our government politically is saying a lot, because they normally don't go against anything that he says. And I hate to say that, but they have very little independence when it comes down to that. But in this particular area, we got more conversations, and the person who was presenting it, I believe it was, what's her name, over DOA, Division of Administration.
Greenstein.
No, he was there. But anyway, she got drilled pretty good on this particular, in this particular area. And again, I think the support is there. And another thing that I'm concerned about is that our government seems to be pushing all of this stuff to us in the state, trying to make all these cuts before ACA kicks in, the Affordable Care Act, which will give us relief for a lot of this. We would have more money than resources, because the federal government will pick up 100% of a lot of these expenses. So I think, again, this is more politically driven than anything else. And we have to recognize that. And when you get into politics, you have the voice. Politics is the voice of the people. It should be. And regardless of where you stood politically, and I tell people this all the time, because let me tell you, a lot of people who supported this administration, they are the ones who are coming to me saying, fight, you know, and it's something that we're gonna have to take on and call it like it is, and deal with these situations. Pick up the phone, call the governor's office. You really like to.
But we must not be disjointed. We must be one voice, meaning the hospice community. There was a great theologian once said, it is amazing what we can accomplish if we're not concerned about who gets the credit. We are one voice, we are one community, and we must always remain in that context. And if we do that, then you're going to see great things come out of this, and that will proceed out of this. But we can't stop here. We must continue to fight.
I totally agree.
Well, first of all, my name is Roy Morris. I'm co-owner of George Crossing Hospice. It's one thing that concerns me, and I want you guys to take it back to Baton Rouge with you, is and offer to Governor Jindal. Every time, or in the last couple of years, anytime that you hear Governor Jindal coming to the North Louisiana area, it's always a photo shoot. It's shaking hands, it's a new business opening. We're inviting him to North Louisiana. Even though I'm co-owner of this company, I spend a lot of time behind the wheel, dealing with the community, finding out their needs, trying to provide good quality hospice care to those in need. If we lose this Medicare benefit February the 1st, you're wiping out an entire population of people in need. Now, one time, since Governor Jindal's been in power in Baton Rouge, have I ever seen his motorcade go through Allendale, pull up to a soup kitchen, find out what the people are needing. None of these, Viral Disease Clinic, Philadelphia Center, all of these agencies and outreach centers will be limited majorly after February the 1st, because a large portion of our population, the poor, persons that are losing their jobs, depend on the Medicaid benefit. And they're going to lose it. They're going to lose it. So we're offering him an invite to come up and just ride with us, or tour the city, talk to the people that are in need, talk to people that have actually experienced the hospice benefit. Because, let's be honest, Governor Jindal will never ever need to utilize Medicaid in his older years. He will never ever. And if you never have to depend on it, it's really not important to you. And that's just how we're feeling right now. It's very frustrating. Like Dr. Cox said, we have to stand as one, we have to be organized, and we have to stay focused. So we're going to stand as one.
Well, let me give you a dose of reality, and I know I've talked too much. And it's not because I dislike our governor, because there are things that I think that he was a smart man, he used it properly. I think he's misadvised a lot from a certain perspective, because he brings in a lot of people, many of them probably not even 25, 30 years old. I hate to talk about age, but they look strictly at numbers.
Right.
And no, you won't get them when you come to Allendale and some of the other, because that's not his voting constituents.
Exactly.
And that's just fact. So we have to take a different approach, because these are the people that we have to deal with. So we have to embrace these, not just Allendale and some of the others. A lot of middle class and wealthy areas that are struggling with this same thing. He'll listen to them because we feel that that's his voting constituents.
We understand he has high hopes and aspirations for DC one day, but as of now, this is just basically unethical behavior, because if we lose this benefit, we're going to have some real problems out here. There's going to be some real problems healthcare-wise. A lot of people are going to go under or not even being served. There's only so much that the agencies, hospice agencies, can do, because it is a such thing as having to close your doors. I mean, if I had to pull out spreadsheets out of our office back there and just see how much we've extended our hand versus actually being reimbursed, it wouldn't add up. I'm almost at a loss of words, and I'm very frustrated at this point. The clock is ticking, so we need action.
A lot of people are frustrated.
Yes.
That is gonna help. I think though, unless Connie has something else, I know my esteemed colleague here probably has something else to go to. I know we all gotta get back. I think we talked about it, I understand. In fact, on the way up here, I was calling DHH on the way up here to say, hey, give you the opportunity to tell me something I can tell. And so I'll probably hear from them shortly. But they probably been calling. Let me say this, I do think that the people want to do the right thing. I think that we have some budget issues, but I do think that your voice is going to be important. I think you should have all your patients call their representatives, send them emails, send something to the governor to voice your opinion. Because stories like what you're talking about, no man, woman, nobody that's got a kid can fathom. And that's why I came over and hugged you, because I had a soldier that lost his son, the only child that he had. And the chaplain came in to try to tell him about God and all this. And I just grabbed him and hugged him, because there was nothing I could tell him at the time, even though God is great. And when you're in that pain like that, and by having hospice helped you have some sense of peace that you did all you could do. I could see it in your face. You did all you could do. And they were there to help you make it and have some sense of dignity. And you hear me use the word living dignity and dying dignity. I thank you guys for inviting us.
Thank you for being here. And I want to say that the name of the campaign is Hospice Cares More and Costs Less. So that's what
Hospice
we're
Care
doing.
More.